There are patients who are not ready to accept that they have diabetes. Why me? Nobody in the family has diabetes, there is no family history, and suddenly I'm not overweight, I'm not having anything, and suddenly I'm having diabetes.
Patient starts the treatment, then the sugar comes back to normal. Now the patient wants to discontinue the treatment. So does that happen a lot? There are a lot of claims on the internet that your diabetes can be reversed. Is it possible? Hi guys. So we have created a series of podcasts to raise awareness. Awareness about what? Awareness about brain stroke. And why? That's because globally, brain stroke is the commonest cause of morbidity. And especially so in Southeast Asian countries like India, where the stroke burden is the highest. And as a matter of fact, it is very concerning also because it is affecting youngsters. And as you guys know, youngsters are the backbone of this country. So we have invited various medical experts, neurologists, neurosurgeons, cardiologists, ophthalmologists, radiologists, to talk about brain stroke and give their vital piece of information, their perspective regarding the same. Now, this whole campaign is being created by a charitable organization called as Purva Medical Trust. And the name of this project is Project Brainline. Now, the main aim of Project Brainline is to create awareness about brain stroke and to create a network of primary stroke care centers throughout the country so that they can respond to stroke and they can treat stroke in the best possible way in the fastest time. And also, from this whole campaign, you will get the vital information necessary to prevent stroke in the first place. And that's why I hope you guys find these series of podcasts valuable, practical, and useful in your daily life. And I hope you guys give us your valuable support. Thank you. Guys, today we have Dr. Sameer Sahasrabudhe on the show. So Dr. Sameer has completed his MBBS and MD and basically caters to diabetes and hypertension. So जो शुगर का प्रॉब्लम है, जो बीपी का प्रॉब्लम है, और उसके बारे में जितना डिस्कशन करो उतना कम है, बिलीव मी, बिकॉज ऐसे ऐसे प्रॉब्लम्स होते हैं जो हमने सोचे भी नहीं और जिसको अगर हम सॉल्व करने की कोशिश करें तो पेशेंट के लाइफ में बहुत बड़ा डिफरेंस क्रिएट होगा. So we are going to talk with him about the practical aspects of treatment of simple diseases like diabetes, hypertension. कुछ सिंपल चीज़ें करके जब ट्रीटमेंट में और लाइफ में बहुत बड़ा इम्पैक्ट पड़ेगा तो फिर उसका सबसे ज़्यादा फ़ायदा होगा. And that is why I urge you guys to watch this video till the end so that you can derive the maximum value out of it and change your life for the better. Thank you. So sir, what are the craziest stories that you have heard from patients regarding diabetes? When you tell them that they have diabetes or they have blood pressure, what are the craziest ways in which they have reacted?
There are variety of stories that patients come with. There are patients who are not ready to accept that they have diabetes. They will get their first report, sugar 400, 300. But they don't have much of symptoms except for might be nocturia, polyuria, which they attribute it to their taking more water at night. So first thing they will do is change the lab, get their blood sugar levels done.
So polyuria is more, getting up frequently for urination at night.
At night, that is nocturia.
That
polyuria
is nocturia.
Increased frequency. So what happens first, as I said, is unless there are gross symptoms of diabetes like fever, urinary tract infection or something, the patient is not ready to accept that he has diabetes. So first thing he will do is change the lab, get his blood sugar levels there. When the second lab also shows that his sugar levels are really high, then he thinks, okay, there is something definitely there. Then they will come to us. Then, depending on how we communicate with them about diabetes, if we suddenly harp on strict dieting, no sugar, no rice, then they become defensive. So, best way is to tell them that no, don't worry. Though the sugar levels are very high, once you take your diet properly and take your medicines well, everything will come under control. So, main thing is to pacify them. Okay, don't worry. You have a diabetes, accept it. Start treating it, and then it will be under control. So, that is one. Second patient's reaction is, why me? Nobody in the family has diabetes, there is no family history, and suddenly I'm not overweight, I'm not having anything, and suddenly I'm having diabetes. And these patients usually come with complications, like they will have urosepsis, they will come with ketoacidosis. And there they have no choice but to accept that they have diabetes and they are suffering. So they get into the hospital or something like that. Many of the patients have a family history that their parents are diabetic. Their health checkups are showing trends where their HbA1cs are on the higher side, they are overweight. And then they come into the category of diabetes. These patients are the ones who know that they are diabetic and they have to take treatment. In case of hypertension, again, same thing happens. Hypertension is called a silent killer because initially there are no symptoms, and especially when the hypertension starts gradually and gradually builds up, they don't have much symptoms. Somewhere for health checkup, somewhere for some other medical condition, they go to the doctor and they find that BP is very high. So again, there is a reluctance to accept that he has it. Then he will say that might be I have just come walking and my BP is high. I had a stressful day and that's why my BP is high. So again, we have to be very tactful to tell them, no, it is possible what you are saying, but we have to monitor your BP. Take 2, 3, 4 readings. And then if the BP is still on the higher side, you have to take medicines, start medicines, because ultimately it is going to cause otherwise end organ damage if you don't heed the advice and don't take medicines. There are some conditions where we have no choice. They come with the high BP, headache, palpitations. There we have to start the medicines immediately. So these situations we cannot keep on pacifying them, delaying the treatment. There we have to start the treatment. So commonest, as I said, in hypertension and diabetes is initially to they are reluctant to accept the diagnosis that they are in denial. Or they are in indirect rage in the sense, why me? But over a period of time, everybody accepts that he has a condition and he has to get treated. This is common for people who are young and middle-aged. For people who are elderly, there is another issue. Majority of our patients are in a post-retirement stage. All the anti-diabetic drugs, anti-hypertensive drugs are costing significant amount of money to take it regularly. Most of them are on multiple drugs, not on single antihypertensive and single anti-diabetic medicine. So while we are prescribing the medicines, we have to be very careful that we don't burden them with medicines which are very costly and difficult to continue to take the medicines. If there are financial issues. If the patient has no financial issues, then usually there is no reluctance. The commonest cause of non-compliance is once if there is a financial issue. Second is if there are multiple scheduled drugs. If I have to take a drug 3 times in a day, compliance goes to almost 50%. If I have to take a drug twice a day, the compliance is 60-70%. And if it is only once a day, the compliance is good, 80-90%. So while prescribing drugs also, we have to be very careful. If I can schedule the drug with lowest frequency, the compliance will be better. So for anti-diabetic medicine, if I can use a long-acting drug once a day, the compliance will be good, control will be good. If I use a single antihypertensive, the compliance is good. But if the patient's blood pressure is in the range which is significantly higher, say 180 by 110, then starting 2 drugs at a time is a norm. While if the patient's blood pressure is on the borderline on the higher side, it is better to start with a single drug. So these are the conditions where patients, we have to cajole them to start taking treatment properly.
And sir, when you start the treatment for diabetes, what is your experience regarding continuation of treatment? Because patient starts the treatment, then the sugar comes back to normal. Now the patient wants to discontinue the treatment. So does that happen a lot, and how do you deal with it?
It happens in the initial stages. Like first thing they want to know is if I exercise, if I lose my weight, if I do regular dieting, will I be free of medicines? That is first. They don't want to continue medicines. Then we have to motivate them. Okay, you start the medicine, lose weight, you have to lose 10 kgs and maintain it for 2 years. Till that time you take metformin, you have a good diabetic memory. So you take it for 6 months. If you don't require it, for long you may not require it. But that is only if you maintain your diet, lose weight and keep a healthy exercise schedule. So that is one. Antihypertensive medicine, again same questions are there. If I don't want to take medicines for life, is it possible to stop the medicine? How I can stop? So again I have to tell them, if your BP is borderline high, you are overweight, you are not doing exercise, start doing all that. Monitor your weight, reduce weight, control your diet, your salt intake should be low, fat intake should be low. And if you control all these factors, there is a possibility that you may be off medicines or your medicines will be cut down to half or less than that.
So then there are a lot of claims on the internet that your diabetes can be reversed. Is it possible?
This reversal is not possible. It is called remission of diabetes, which is the ideal term. So as long as you diet, as long as you exercise, as long as you control your weight, you can go off medicines.
Okay.
But that doesn't guarantee you that you go back to your normal lifestyle. You will go back to the sugar levels which will mandate you to take the medicine again.
So
it is remission. It is not.
It's not reversal.
Not
so
reversal.
What they are claiming,
reversal is not a correct term. Remission is the perfect term, and that remission is conditioned that you have to do all this: significant dietary restriction, weight loss, and exercise. If all these three is maintained, you can become off medicines or significantly less medicines.
For as long as
you maintain
doing
this.
those changes. Once you stop that,
you cannot. Even with newer drugs, Ozempic and all drugs which are weight reducing drugs, actually they were invented as anti-diabetic drugs. And now people are taking it for weight reduction. But even there, all this can happen only till you take the medicine or injection. The moment you stop taking it, you are going to go back to your initial stages, gain the weight, start anti-diabetic medicines again and all that.
So then the thing is, because a lot of people are claiming these days online that they will help you in reversal of diabetes. So first of all, we need to, I think, make people aware that reversal is not possible.
It is remission. And remission is not requiring medicines till you follow the
only till you
parameters.
Follow the
and
changes
maintain
in
the changes.
Maintain the changes.
The moment your control is gone, you will go back because your beta cells are damaged. When you are diabetic type 2, your beta cells are damaged. What you try to do is increase your insulin sensitivity by exercise, try to increase the beta cell function by exercise and dietary control, and you limit your sugar levels.
So these beta cells, they release insulin. And insulin is required to control
sugars. That is one. And the second one is, what is common in type 2 diabetics is insulin resistance. You may have enough insulin, but that doesn't act on the muscle cells where it will break down glucose or it will be utilized.
So even after having enough insulin,
you can still be a diabetic. You have insulin resistance.
Right. Okay. And that was about reversal. Now the other thing is, this is a very drastic lifestyle change, right? A diabetic patient, up until that person is diabetic, will eat whatever he or she wants and have a lifestyle the way they want. But once they are diabetic, now they are very serious about remission. They have to make big changes in their lifestyle. Sir, in your experience, how do patients manage to get adapted to this lifestyle change? Because you mentioned that once they do that change, their sugars will
come down
in better control. But then the change itself is very difficult to make.
It is not a normal lifestyle.
It's not a normal lifestyle.
It's forced on you. So it depends on how convinced you are to do that, how motivated you are, and how prepared you are to compromise. Because the rule says actual weight loss by diet and exercise or whatever it is you can achieve only 10% of your weight.
Okay.
So if I am 100 kgs, I may go down to 90 kgs, not below that. But what is weight loss is when you start losing the weight to 2 years. So I should be able to maintain my
Weight loss.
lost till 2 years, not 3 months. 3 months everybody will lose just 20 kgs also. But it is very difficult to sustain that level of dietary restriction and exercise for 2 years. So when they calculate, they say ki at the end of 2 years, what you lose, maximum you achieve is 10%. That's why bariatric surgery came into picture. If beyond 10% to lose, you need something else. So bariatric surgery, then the newer drugs, Ozempic, or all these drugs, they started coming in. Or weight reduction drugs started coming in. Because only diet and exercise was not sufficient to maintain that weight loss. Short-term weight loss was possible. Long-term it was difficult.
And what exactly happens after weight loss?
One is your insulin resistance goes down. Body's capacity to utilize glucose increases because you are exercising. So your demand goes up. So obviously your sugar levels go down. That is one. For blood pressure, more you exercise, more your BP will be less because the resistance of the blood vessels will go down. So the moment resistance goes down, they will dilate and the pressure drops. So exercise, aerobics will help in drop in pressure. While anaerobic exercise, there you are straining yourself, the blood pressure may go up. So when the patient is hypertensive, we usually tell them not to do anaerobic
training,
exercise,
anaerobic.
strengthening, weightlifting, bench press and other
Okay, that they should not
that
do.
they should not do till their blood pressure is under good control, especially as you age.
Right.
Because
Okay.
Young patients usually are not worried, but there are a good number of young patients now who are addicted to exercise, which is good, rather than getting addicted to drugs,
Other
and,
things.
drinks and smoking and everything else. But normally that awareness about exercise comes into 40s when you start getting hypertension, diabetes. And there we would like our patients to get their initial assessment done, hypertension, if they are hypertensive diabetic, get a 2D echo, get a stress test, then rule out underlying silent underlying ischemic heart disease before you go for vigorous exercises, vigorous strengthening, because that can be deleterious otherwise. Where we have heard stories where people have collapsed on treadmill, people have collapsed while they go for marathon running, people have collapsed where they are going for trekking and hiking. That is because underlying heart disease is undiagnosed.
Right, and they are not used to
Not
that
used
amount.
to that, and then they suddenly start doing exercise which is beyond their capacity. So that has to be well understood. Like when you start exercise, especially beyond middle age, you have to get your cardiac assessment done well. Walking, swimming, cycling, unless you are having some problem while doing it, you can easily do it to the capacity which your body allows you. Anything beyond that, you should have your doctor's advice, stress test and echo done, and get your blood sugar and blood pressure under control.
Right. And so this was about exercise, but there are a lot of restrictions when it comes to diet, especially a diabetic diet. So when a person switches from a normal diet to diabetic diet, I think the most common complaint must be, sir, for how long will I be able to do this?
So this
It's not sustainable. That's the word, sustainable.
sustainable. That
So
is-
how then how to tackle that problem?
That's true. What happens is, when we tell them that no sweets, no rice, nothing, then they are on the back foot but defensive. What you have to tell them is, first, everything in moderation. Rice, potato and everything.
You can
carbs
have.
You can have, but you don't have to
Moderation.
stop in moderation. Reduce
Okay.
it by half. Direct sugars, stop. Don't take anything, sweet sugars. At least till you get a very good control. Fruit sugars you can have. There are very few fruits which you can avoid. Most of the fruits you can have. So fruit sugars you can have. Complex carbohydrates, which are difficult to digest, carbohydrates with high fiber you can have. And once you are very tightly controlled, well controlled, you can have cheat days. Like not that life is only sugar free. You can always have. There is a celebration in family. You have it a day or something. But that is with a caveat that your sugars are well controlled. So we don't deprive them of the liberties of life to the extent that they feel they are JLR or something like that, they have given food which is not first class, or when everybody else is enjoying, I'm not able to do that. So if we tell them that everything in moderation, good control, if you add your exercise diet, your good medicines, you can have a little bit of liberty in your diet like rice and other things. So plus whatever local food is available, you should try and eat that. Somebody tells you get ice lettuce and then increase your fiber diet, it will be difficult. But main idea is when you get this, your fiber or your this should be almost 1/3. Your protein should be high and your carbohydrates should be reduced. That type of diet you should take.
And we were talking about weight loss earlier. So this is what we ask every guest on this podcast so far. That would you recommend intermittent fasting, or what are your thoughts on intermittent fasting?
Intermittent fasting per se will be 16 hours.
Right.
But if you do it 12 hours, it can still be labeled as intermittent fasting. What I mean to say is, try to eat maximum what we are hearing for generations. Breakfast like a king and your dinner should be like a pauper. In between, as per your activity availability, you can have a lunch which is fine. But have a breakfast like a king, in the sense have maximum calories during your breakfast. And at dinner it should be a frugal diet, which will not load your digestive system to work overtime at night. So more rest to the digestive system at night, because that time your brain is not functioning, your heart is not functioning. That is what is considered, like you are resting. So you take your lunch, dinner, and then you probably not are going to have any vigorous physical activity. So probably you require less calories. So have a smaller dinner. Have a dinner which is not very spicy, so that you don't get reflux and all. And you can sleep peacefully. Then quality of sleep or time of sleeping. What we tell our patients is, by 10 o'clock all your TV, mobile, iPads or any other electronic inputs, preferably if you can avoid, you should avoid. Try to create an inducive environment to have sleep. And try to sleep 6 to 8 hours. To be frank, 8 hours sleep is a dream.
That is true.
To have a normal person to get 8 hours sleep is impossible.
Impossible.
6 hours is fairly okay. If you can manage 6 to 8 hours, nothing like it. Preferably sleep before 12 o'clock, by 10 o'clock. Get up early as possible, 5, 6, 7, whatever is your schedule. You should have at least a morning walk or yogas or meditation or whatever it is to start your day. So start your day peacefully. Start moderate exercise or mild to moderate exercise. Have your breakfast. Start your day-to-day life or day-to-day routine and continue to work in a day. But this is for a normal person. Somebody who has a night shift has to adjust his food pattern accordingly. Like sleeping pills somebody is taking at night, a person who is working at night will take it in the morning when he comes from the duty. So that adjustment he has to do. But majority of the people can follow lifestyle. For a youngster, it is very difficult to restrict them. Especially young people, Modi, who are early diabetics or young diabetics, type 1 diabetics. They are brittle diabetics because we cannot control their activity, we cannot control their food pattern. So that is a different group of patients where we have to tackle them differently. But when we say a diabetic hypertensive, we usually talk of a person who is between 30 to 60, where his lifestyle is fairly regulated, his time schedule is fairly regulated, and he can make some adjustments.
He can have some control.
Have some control on his activities. If you are near 60s, you can cut down all your activities beyond 6 o'clock or beyond your dinner. In 40s, might be there is work pressure or performance you have to do which you cannot avoid. Then try to adjust as much as possible. 100% adjustments are not possible. There the drugs come into picture. If you cannot... See, it is not possible for everybody to have 0 drugs and only diet and exercise. So you will require a drug. So try to minimize the drugs as much as possible. Minimum required for diabetes. For blood pressure is maximum tolerated. So a blood pressure of 140/90 with one drug. If I can bring it up to 120/80 or 130/80 with two drugs, I should give two drugs. Because your organs will function better at lower the pressure which is tolerated.
Okay.
And blood pressure norms have changed over a period of time. It was initially linked to your age. So beyond 50s, 150/90 is fine. Beyond 60s, 160/90 is fine. Beyond 70s, 170/90 is fine. This was initially. Now they say 140/90 is upper limit for all ages. For a diabetic, 130/80, 120/80, lower the possible is ideal. Because they have a tendency for target organ damage. So lower the blood pressure, lesser the target organ damage. We should titrate the blood pressure drug such that the patient doesn't become pre-syncopial or they don't have postural hypertension, especially in elderly.
Okay.
Especially in elderly, when we are giving antihypertensive drugs, we have to be very careful. We have to think of two things. When they come to the office, in the clinic, the pressure is usually high. And we tend to adjust their doses
According to that
the
pressure.
targets because according to the blood pressure that we record in clinic, which may be sequentially always on the higher side. The moment patient goes home and is in a relaxed situation, his blood pressure drops. Especially if they are on beta blockers, if they are on diuretics, they tend to have postural syncops, or especially early in the mornings, falls, fractures, head injuries, intracerebral bleeds. So these things we have to be very careful. So again, now the concept has really changed a bit. Like in hypertension, again that concept of 150/90 for elderly is come. Same thing has happened in diabetes. When HbA1c was considered as a target to control your
It
diabetes.
is 3 months blood sugar.
Average blood sugar, which gives you about last 3 months control in blood sugar levels. So when it started, it was like it should be less than 7, it should be less than 6.5, it should be around 6 as much as possible. But then they realized as the patient ages, if we try to control HbA1c blood sugar levels purely by HbA1c and not by fasting and PP, there were many incidences of hypoglycemia. And hypoglycemia is more deleterious than hyperglycemia. A patient can die. Reduced hypoglycemia is drop in blood sugar levels. Because hypoglycemia puts a lot of stress on your heart, brain, every organ. So now the targets have changed. In US, you are beyond 70, your target of HbA1c is 7.5. You are beyond 80, target is 8, which Indian Diabetic Association still doesn't accept. It is around 7 to 7.5. But by convention, by common sense, more the age of the patient, your HbA1c target should go up.
And if the patient is young
Then active,
and the patient wants to
have a good quality life because he has much more life to lead and to prevent microvascular complications, which are peripheral neuropathy, dilated cardiomyopathy, CKD.
these complications happen because the small blood vessels
in the body get damaged because of diabetes, glucose stress.
That is called as
That is called
microvascular
damage, where there is inflammation of the vessels and the vessels get blocked. Many times in diabetics, you do an angiography, you will find all the epicardial coronaries are normal. But then he gets all the symptoms, not chest pain much, but chest pain also, but significant dyspnea on exertion. They become breathless when they exercise, when they put in an effort, because they have a microangiopathy and microvascular occlusion in the heart vessels. There the concept of collaterals, developing collaterals, or promoting to develop collaterals where your regular exercise matters. When you exercise, walk regularly, you exercise your heart and the heart develops collaterals. That's why if you see, when the patients are elderly, regularly exercising, even if they get a heart attack, they don't go into heart failure immediately sometimes, if they have very good collaterals. Because if one vessel is blocked, the other side is supplying. As against that, when a young patient gets a heart attack, he has no collaterals. And he can have no blockage in the coronaries. There is just a vasospasm, but there is a huge left ventricular muscle damage. Because by the time he comes to you thrombolyze, there is tissue hypoxia and there is scarring of the myocardium. So that is the difference between a heart attack in the elderly and heart attack in a young patients, where they can have a massive heart damage but no coronary occlusion or a very small coronary occlusion. While elderly, you can have significant vessel damage, but they will not land up with significant muscle damage.
Also, sir, when young patients come and they say, now I've been detected with diabetes, but I will make all the lifestyle changes which are necessary. But, sir, will the diabetes go away? In young patients, recently detected diabetes, is it possible?
There are 2-3 things. If he has no family history, if he has no genetic tendency to have a diabetes, or any illnesses like childhood pancreatitis or abdominal illness or something where his pancreas may be damaged, and somebody who has developed diabetes purely because of bad food habits, overweight, lack of exercise, and if he loses significant amount of weight over a period of time and maintains that weight loss lifestyle, there are chances that he will remain in remission for long.
For long.
For long.
But it's not permanent.
We don't know. If he maintains that lifestyle and weight loss, unless he will not develop diabetes or he will not develop sugar levels to require blood sugar reducing medicines. But that is not a guarantee. But we can always assure them, you maintain this, you will not require medicine. You have to keep on checking blood sugar levels. Like a pre-diabetic, check it every 3 to 6 months. And then monitor your weight, monitor your exercise and keep yourself off medicines. Like we say, in a non-diabetic, no family history, you check your blood sugars after 40 once a year. If you are pre-diabetic or you have a family history, check your blood sugars at least 2 to 3 times in a year. But if you are diabetic, then you have to check your blood sugars ideally every week, otherwise once in a month or once in 2-3 months. Same way for blood pressure. You should regularly check your blood pressure. Especially if you are reducing your medicines, what happens is we give them 1, 2, 3 medicines to bring down their blood pressure. Then they record that their blood pressure is continuously on the lower side, and then they will start reducing the doses.
They self-titrate.
They will not come to us. They will self-titrate. Till they are on medicines, they keep on checking the blood pressure because they want to stop the medicine. There is a time when sometimes they don't need a medicine or they stop all for 1 week or 2, they don't have any rise in blood pressure, they stop checking. And there is a problem sometimes if they don't check your blood pressure again, they will again come back to us with sudden rise in blood pressure if they are very unfortunate with a stroke or myocardial infarction.
So once the patient has hypertension or diabetes,
you should never forget that you have diabetes and hypertension
for
and
life.
Take medicines if required, keep checking and keep under control. And lifestyle modification.
And sir,
unless for blood pressure there is a secondary cause.
Okay.
So there are certain conditions which cause hypertension. Say I am hyperthyroid. My thyroid function is controlled. I may not require medicine.
If it is because of some other reason like thyroid
condition, thyroid, kidney stone, then kidney vessels which are blocked, renal artery stenosis, you correct that. You may not require, or at least your dosage will come down.
And sir,
if you have a adrenal tumor, there you treat it, you may not require medicine, or your requirement will go down. So these are secondary hypertensions, which may make you hypertension free or moderate or mild hypertension. That is possible.
And sir, if let's say for example there was a party and a young person who never had diabetes eats a lot of sweets, will he get diabetes just by eating it once?
By eating once, he will not. But there is something called as glucotoxicity.
Okay.
If you keep on hitting your body or your pancreas with excessive demand, with binge eating, there will be a time that sugar levels will go up.
Okay.
Especially if you have a very strong family history.
Right.
So your covert diabetes will become overt. So
okay.
Especially particular food, mangoes. If you keep on eating mangoes, instead of 1 or 2, you harp on mangoes day in and out, there is a possibility that glucotoxicity will produce diabetes. Whether it will go back, become nil or not, only time will tell us how much damage has happened.
So in a normal person, if that person eats excessive sweets, the sugar will never cross the
No,
normal
it will
limit.
cross definitely.
Achha, it will still
It will
cross.
still cross, no? Because there is ultimately limit to it. You keep on, but body tries to secrete insulin, bring down your sugars. But if you say like if you give somebody glucose, like
If you
glucose
eat 10
tolerance
mangoes,
test,
huh.
or glucose tolerance test, you want to try what happens. So beyond, so that's why you give only 75 grams of glucose, because that is normal intake of glucose. If you give him 150, 300, 400, he's not going to cup up. It will take time. So instead of getting his sugars below normal in 2 hours, it may take 3 to 4 hours. But that is a one-time incidence. If it keeps on happening, then over a period of time, the body will lose control and its sugar levels
Okay,
will
so
drop.
it's interesting to know that, like, let's say, for example, it's a one-time event, and somebody, just because that person loves sweets, has a sweet tooth, eats a lot of sweets, the sugar will definitely go beyond the normal levels. And if at that time that person checks,
It will be high. Like I eat sugar and I do it in half an hour, my sugar is alright. I do it after 1 hour, it will come down. By 2 hours, it will come to normal.
but they will be much higher than normal.
Sometimes, depending on how much you eat, how slow you eat. If I eat over a period of 4 hours, it may not go up. But if I am in a
Binge eat.
competition, say, it used to happen in marriages. 16, 20, 30, 50 gulab jamuns at a time. There used to be jalebi eating competitions. People used to do that. I don't know whether you have read Kishore magazine in the past. There was a story of a person. He was a priest who used to go to pujas to different places. And everywhere he was fed. So at one place he ultimately says, now don't give me anything. If I put in my finger in my mouth, there will be a srikhand on the tip. That much I have taken. So, this is anecdotal. What I mean to say is, see, but then there were people who used to eat whatever they want to eat. But then they used to work in the farms, they used to exercise. So ultimately what is important is the calories you take in, you have to spend those calories. If you don't spend, they are going to be stored. They are going to tax your systems, digestive system, your pancreas, your kidneys, everything it is going to damage.
And all this is again related to brain stroke and everything.
So ultimately, the duration of blood pressure is one, and sudden rise in blood pressure is another. If your blood pressure suddenly shoots up, say from 160 to 220, you can bleed. You can have a brain stroke. Not only bleed, as you age, your vessels become thick and hard, more so in hypertensives. So at the junctions in the brain, they can crack. They will develop a clot over there, and that clot can get dislodged. So they can have a ischemic stroke where there is a blood clot in the vessel which blocks the blood supply, or sudden rise in blood pressure can produce a rupture of a vessel and a hemorrhagic stroke. So they are at a risk of this. Sudden spurt of activity, sudden rage. Say you are angry with somebody to the extent that you lose your control, you go beyond your capacities, your blood pressure shoots up to the extent you can collapse and die. Especially if you are hypertensive, especially if you are beyond a particular age, you have to be very
Extreme
careful.
emotions.
Extreme emotions. Something similar can happen to the heart, broken heart syndrome. They can have a dilated myopathy where apex of the heart dilates. Same thing, the reason is same, sudden surge of adrenaline, dopamine and everything which shoots your blood pressure up. So that is a dangerous thing. But blood pressure also has a damaging effect on your blood vessels, on your brain organs. So even if your blood pressure is fairly under control, irrespective of that, your vessels are going to harden, they are going to be inflamed, they are going to develop plaques, and they are more prone for blockages. So this is irrespective of how good you control. That is a process of aging. A normal person who has no diabetes, no blood pressure, may not have these changes, say, up to 70 years.
Okay.
A diabetic hypertensive may start developing those changes at 50 to 60 years. Drugs for hypertension like ACE inhibitors and ARBs are known and shown to delay this vascular damage, prevent your kidney dysfunction, delayed by at least 5 to 10 years. So you should take these medicines as advised by your doctor. So these medicines don't only control blood pressure.
Right.
They also control your vascular damage, also control your end organ damage, and your organ function is taken for a longer time. So normal person's organ, whatever it may be functioning at 70, you as a diabetic are prone to develop that much damage at 50. You take good drugs, control your sugar and blood pressure, you may have that function till 60. So you have a 10 minutes, 10 years additional
Additional time.
function, you can say.
So,
So that is the benefit of taking medicines as advised by your doctors.
so even if nothing is happening, even if your blood pressure and sugars are under control, you have to continue taking
your
those medicines.
because those medicines are known. So diabetes is not only blood sugar. It is one part of it. Diabetes has effect on multiple things, muscles, body organs, everything. So different medicines have different functions. Like now, any new diabetic drug has to have the cardiac safety. CV safety is first. So there are some diabetic drugs like dapagliflozin, which was invented as an anti-diabetic drug. Now it has shown that it prevents heart failure even if you use it in a patient who is not diabetic. Because the efficacy of the drug is such that it prevents hospitalization because of heart failure. Your effort tolerance improves. So now dapagliflozin is used as a anti-heart failure drug rather than a diabetic drug. So that is the importance of newer drugs, which they are costly, but then they are good.
Because whenever such things happen, whenever a patient gets to know that he or she has diabetes or hypertension, once it is under control for like 2 or 3 years, then first there is the initial phase when things rapidly get under control, and then the patient wants to get off the drugs. But then we tell the patient, "Ki baba nahi, this can't happen. We have to keep on taking these drugs for some time for your health." But once 2 or 3 years go, then the patient starts thinking, "Now I've taken these drugs for a long time. Now I want to stop." But they should not.
They should not, yes. Unfortunately, whatever you do, 50% of the patients will not follow your advice.
50%.
50% or more. Reasons may be different. Financial, as I said, lack of time. They will have time for everything else, but not for regular follow-ups. It is not their fault. Even for us as doctors, we are the worst patients. If you see your lifestyle, we don't follow properly. Medicines, we will be the first ones to default. If my doctor gives me 5 medicines for cold, cough and fever, I know I don't have much of headache, I will not take his paracetamol. Cough syrup I may avoid. So me as a doctor is more prone to default from this. That is apart. What I mean to say is, whatever we tell our patients, they are not convinced. And once they stop their drugs, they don't have anything immediately. Unfortunately, मराठीत जी म्हण आहे, पुढच्याच ठेस मागचा शाणा होत नाही. प्रत्येकाला स्वतःचीच ठेस लागायला लागते, त्याशिवाय तो शाणा होतच नाही. आणि ते दुर्दैवी आहे, कारण आम्ही आमच्याकडे यंग पेशंट्स बघितले की जे IC ब्लीड घेऊन येतात. दे कोलॅप्स, दे कम इन कोमा, दे कम इन सीजर्स, convulsions. Many of them die before coming to the hospital. Mortality is more than 30% in IC bleeds, where majority of the patients don't reach the hospital. Even after reaching the hospital, if there is a IC bleed, mortality is still 30% more. So if you calculate, out of an intracerebral bleed, only 40% survive. Out of that 40, more than 30% have significant deficit, neuro deficit. So the quality of life is not good. So the person, if he is from an earning age, say 35, 40, whole life ahead he has to survive with deformity. So there is loss of income, loss of mobility, and expenses of medicines and this. So this all is preventable if you take your medicines regularly. We say, गाडीला ब्रेक लावल्यानंतर गाडीचा ॲक्सिडेंट होणार असं नाही, पण 50 ॲक्सिडेंट मधले 40 तरी वाचवले जातील. 10 जे होतील त्याचं काही कारण नाही. Somebody else may do something. Same thing for blood pressure and diabetes control. If you control it well, काय होतं, शॉर्ट टर्म लोक बघतात की काही होत नाही, मला काहीच होत नाही, मी कशाला फॉलो. सो लाईफस्टाईल मॉडिफिकेशनचं बिगेस्ट हर्डल इज शॉर्ट टर्म ग्रॅटिफिकेशन. जाऊ दे, आज गटारीचं नाही देत एक्झाम्पल, पण न्यू इयरचं मुळे की मी जानेवारी 1 पासून आता डाएट करायला सुरुवात करतो. पण ते म्हणताना आय स्टार्ट इटिंग वॉट एव्हर आय वॉन्ट टिल
Till that
31st
time.
December. And then January 1st comes and it goes. For few days or months you will follow. So that is one. दुसरं पॉसिबिलिटी आहे की फायनान्शियल रेस्ट्रिक्शन्स. लाईफस्टाईल मॉडिफिकेशन इज नॉट फ्री ऑफ कॉस्ट, इट कम्स ॲट कॉस्ट. तुम्हाला तुमचे शूज पाहिजेत, तुमचे ड्रेसेस पाहिजेत, टी शर्ट पाहिजेत, वॉकिंग एरिया पाहिजे, नाही तर मग जिमचं मेंबरशिप पाहिजे. म्हणजे दिस कम्स ॲट अ सिग्निफिकंट कॉस्ट. तिसरं इज यंग एज, युअर टाईम शेड्यूल, लाईफस्टाईल इज सच दॅट यू कॅनॉट फॉलो युअर एक्सरसाइज. मी 3 दिवस चालायला जाईन, 4थ्या दिवशी मला कॉल येतो चल कामाला ये. किंवा हॉस्पिटलमध्ये काम करत असेल तर म्हणून नाही जातो, इमर्जन्सी आहे हॉस्पिटलमध्ये. सो ऑर नाईट मला माय टाईम ऑफ कमिंग बॅक होम इज नॉट डिसाइडेड. आय गो ॲट 8-9 बट वेन आय कम बॅक इज नॉट डिसाइडेड. तिसरं इज मेनी पीपल स्टे hours away from their workplace. So worst part in Mumbai is they work in Mumbai, stay in suburbs, and traveling from
That is
their
so
workplace
common.
to home, you will take almost
1 hour,
half of
1.5
half
hour.
of their working time. So they work 8
6
hours,
hours.
they travel for 3-4 hours. So what time is left? How you expect them to do all this and take 6 hours sleep? So it is very difficult. So that is because of the lifestyle. And third one is, as I said, negligence. Many of them are negligent. नाही काही होत, जाऊ दे काही होत नाही. पण ते, it is in our hands. If you can really convince them, show them examples. If something happens in the family, then many of them are motivated. Like what we see commonly is, company मध्ये somebody dies. Young. 90% of the company people will go to their doctors to check their heart, ECG, blood pressure. So that time is the time when we should hit hard on them that yes, this is what you should do so that something similar will not happen to you. So at least preventive health. And other good thing about preventive health checkup is so many times blood pressure and diabetes is detected. There are so many things which are not required, but if the person is not spending from his pocket and his employer is doing it, it is good. Diabetes, dyslipidemias, cholesterol levels going high, blood pressure. So many times they are
At
not aware
least
and it is detected.
that person
and
is
it
able
is
to-
detected before the damage is done. So that is the right time that we can
At
treat
least
them.
he is able to catch it early.
In time, early. So that is the advantage of having preventive medical health checkup.
Because by what you are describing, it seems that patient behavior itself is a very big part of treatment. If patient changes their behavior, they'll definitely
Change it to significant level, but then that is the human nature. Human nature. So it is very tough to change you
No,
from
but
what
sir,
you are.
patients, let's say for example in the Western countries, they take their doctor's advice very seriously as compared to Indian patients.
Yes.
As in, this is what at least I have
Then I will tell you,
heard.
there are reasons. And I was coming to that. One is education. Most of them are at least educated till 10th and 12th. If you consider India's population, education is good in cities, but education level is not as good. Second one is conventional, traditional things. Like if you are started on antihypertensive, anti-diabetic medicines, you are looked down upon by your peers, your community people. अरे 30 वर्षाचा आहे तुला 4 गोळ्या ब्लड प्रेशरच्या खायला
That is
60 वर्षाचा आहे मला एकही नाही
actually
खायला.
very big issue.
And it is the biggest, they come depressed. Sir,
Yeah, I am just 30 years old.
मला एवढं घ्यायला लागतं.
मला
अरे
एवढं
म्हणलं, तुझी फॅमिली हिस्ट्री बघ, त्याची फॅमिली हिस्ट्री बघ, देर मे बी सम चेंज. तुझ्या घरात यंग डेथ्स असतील, सडन कार्डियक डेथ्स असतील, सो देन यू हॅव टू बी केअरफुल. त्याच्या घरात नसतील तर ही इज लकी जेनेटिकली, बट दॅट डझंट मीन ही कॅन बी रेकलेस. There are modifiable, non-modifiable factors. Modifiable factors, if they add to him, he can still, but it is for him. You follow what you want to do. Don't listen to somebody who is saying that, "Are every medicine kai?" Because you have a disease, you need so many medicines.
I think especially with insulin is
is
म्हणजे लोक घेतात त्यांना लाज वाटते घ्यायला insulin.
Yes.
And that is why they don't take, insulin two times, 3 times a
3
day.
times a day. इन्सुलिनची स्टोरीज वेगळी आहे. म्हणजे डायबिटीसवाला पेशंट will be very reluctant to start insulin. There will be a time in his life somewhere where he will require insulin.
So we'll have to
We'll
start
have
insulin.
See, we'll tell them your kidneys are going to die before you die. So because of diabetes, your kidneys life is lesser than your life. Your heart, brain may be functioning more than your kidneys. So there will be a time where your kidney function will start dropping, where your drugs will be dangerous. Oral hypoglycemic agents will be dangerous. A drug which is supposed to work for 8 hours will stay in your body for 12 hours, 14 hours.
Because
So
the drug is
because
not
drug is
filtered out.
excreted by the kidney. And then what happens is it keeps on pulling, and over a period of time, sometime you will become hypoglycemic.
But suddenly, initially when that happens, the patient is very happy that
No,
all my sugars
that
are
is the honeymoon period,
Uh-huh.
where they feel that their sugars have suddenly come under control.
control.
And then they are related. My sugars are controlled.
And they forget to check
Forget
kidney.
to check kidney function. It happens especially when you age beyond 50s. So that is there. Insulin, 3-4 things again. Cost of insulin. It was bovine, it became human. Cost went up 30%. From human insulin, it has become analogs.
Analog.
Cost has gone again 30%. They are good medicines, they are good insulins, but they are not affordable to everybody. Especially people who require insulin are in a post-active life stage where their incomes become restricted. They have to take out X part of their income for medicines. And suddenly your insulin comes in, it takes a chunk out of their medical expense. So you have to be very careful when you prescribe them insulins. You have to convince them that when you take insulin, your quality of life will improve. And if they take it for a month or so, they themselves will realize gastritis, weakness, tiredness, fatigue, everything goes. And the quality of life improves with insulin. Rather than going on polypharmacy with multiple drugs, multiple class of drugs for diabetes, it is better to have 1 or 2 class of drugs and an insulin. That is ideal. Or basal bolus or whatever it is. But here your doctor-patient communication, doctor-patient relationship, how long you are treating the patient, and other important thing is I have to be very careful in preparing my patient to take insulin. So as I said, when their sugars start dropping, I start the topic of insulin. I start the topic of kidney function, kidney life, quality of life. I tell them examples how this person came, how he was on insulin, how see now he is walking. So mentally they are prepared to take insulin. Then we will give them basal insulin one time, insulin once a day. So they know how painless the needle size, because the needle size has gone to 31 G, which is almost painless prick. Like testing a blood sugar is more painful than taking an insulin. So there, if we convince them, they will take. Patients who come with complications, the issue is not much because we put them on. Then the issue comes when they go home and then they don't want to come back. But if their kidney functions are good, we'll put them back on OHs, oral hypoglycemic agents. So that is one. And third one is insurance. The people from Western countries, majority of them are educated. Second is they are insured.
They are insured.
The moment they are insured, they are motivated to get preventive health checkups done, because majority of the insurance companies allow you to get preventive health checkups done.
Routine health
which they are
checkups done.
compensated. When you are insured, you seek medical help immediately. You don't have to think of finances. So, plus you have access to medical health. Once you are insured, an insurance company, many of them have their ambulance services. So the ambulance will come and pick you up. So in Western countries, medical emergencies are very well handled. 911, emergency calls, their insurance companies are vehicle. So that is a major difference. And so their adherence to medicines is good. Because the insurance company will give them incentive not to get ill and keep on paying premium. Because more they adhere to their lifestyle medicines, less the burden on the insurance company. So it is two-way. In India, 70% plus, now 70 because government schemes are there. Medical expenses are out-of-pocket expenses. And the moment they become out-of-pocket, medical emergencies and medical expenses are one major reason to pull a patient or a person from being above poverty line to get below poverty line. Medical cost of medicines, cost of medical treatment has gone up so much. That is also the reason why the conflicts are increasing, because there are out-of-pocket expenses. My gut feeling is I should promote medical insurance of whatever company, whatever this, a patient should take medical insurance as early as possible in life. Younger the patient, lesser the premium, less comorbidities, he is covered for everything. So the idea should be when we gift people some gifts, it is better to give them an insurance policy as a gift for a person who is in, say, a newborn. The moment he becomes eligible for insurance, he should be insured. That is the ideal age to get insured. Because the moment you are insured, your health will be on track. You will be ready to spend for your health because it will be reimbursed. And once you have no comorbidities when you are insured and your insurance is continued, all expenses are taken care of. But you have to be careful now to increase your insurance amount because the expenditure has gone up. So say 10 years back 5 lakhs was the good insurance. Now it is 1 crore almost. Because the cost of malignancies, cancer treatments, heart treatment, brain treatment has gone up into multiple lakhs, which was not so. So everybody should be aware that he should get an insurance. People, now government schemes are good. It will take some time for the health infrastructure to come up, but it will come. Government is trying their level best to boost the health infrastructure. But at least everybody, now in Maharashtra, everybody is insured for 5 lakhs. Whether you
At
have
least.
a yellow or orange ration card or you have a white ration card, if you go to a empaneled hospital, you get treatment free for 5 lakhs. That is a promise of the government. That is a good government scheme. Pradhan Mantri Yojana is also a good initiative. And people have to be aware. It is not only government's activities. People have to be aware to take advantage of those activities, get insured, be careful about their lifestyle modification. And like recent there is a news, Australian government has restricted social media availability to the children.
I saw that, yeah.
The whole idea of that is that they should restrict their activities beyond, say, XYZ time in the night so that they concentrate more on their studies, concentrate more on outdoor games. That is what the government may be doing it. Bringing in laws may not help. Social reform is the thing. You have to train, teach and imbibe on them that more you go out and play, lesser chance that you will be hypertensive and diabetic in future life. So that is what. Complications. Actually, we have talked of all till prevention and disease control, blood pressure and diabetes control. Now, what happens when they land up in problem? Like we are dealing with brain stroke, heart attack and brain stroke. 80% of the brain strokes almost are ischemic strokes. Like what happens in the heart, coronaries get blocked. Same thing happens in the brain, carotids and their branches get blocked. And the tissue which they supply dies. Same thing happens in heart. Same thing heart, as you age there are collaterals. More you exercise, more collaterals. Same thing happens in brain. Plus in brain, fortunately there is a circle of Willis. So the vessels crisscross. So that is a natural safety mechanism. If one side gets blocked, blood still comes to the brain from the other side. That is a natural safety mechanism. Plus development of collaterals will give additional boosters. So the damage will be less. What we have to be very careful about is bed effect.
Bed fast.
What Dr. Hande was telling in the podcast. You have to be aware of all the signs and reach heed of those signs and reach the healthcare as early as possible. Because earlier you reach, better is the treatment outcome. So word around concept, initially it was 3 hours, now they have expanded it to 4.5 hours. But 1 hour is the best, 3 hours is better. 3 and 4 hours is slightly possible. Beyond 4 hours, if there is a major vessel block, still you can go ahead, do an intervention where thrombosuction and everything can be attempted. But that is the intervention where you have to go to a tertiary care center. But in a stroke, if you reach a medical facility early, the doctor will be in a position to offer you thrombolysis if feasible. Once you reach, you have to get the scan done fast. Plain CT is good enough. MRI ला वेळ जाणार, time असणार, weight असणार.
At least plain CT, you
Plain CT you
understand
rule out bleed.
how to treat, how to
And
proceed.
on the chart, which level of deficit you can thrombolyze, which level of deficit you should not, and which level of deficit is useless. Like if I have a very small deficit in left upper lap, I should not,
Okay, you should not.
because it will recover on its own.
On its own.
If I had only TI-like symptom, say power loss for 6-8 hours, I should wait and watch. I should give everything, antiplatelets, statins and everything.
You should not thrombolyze.
Thrombolysis is not indicated on
It's
this
not
small
required.
stroke.
Right.
A large stroke, if I thrombolyze, there are chances that it will become a hemorrhagic stroke. Complications chances are more. So the risk is more than benefit. Medium-sized stroke, good indication. Right-sided stroke where vision has gone or speech has gone, irrespective of the size, you can thrombolyze. Because whatever recovery you can get is beneficial.
And also, we were talking about it earlier that, and we have not discussed it in any previous podcast, is thrombolysis. So, thrombolysis, what we mean by thrombolysis is the doctor will give you an injection.
It is an injection which destructs the clot.
Dissolves the clot.
Destructs the clot. So that is thrombolysis. Aspirin, clopidogrel, these are antiplatelet agents.
They are different.
They are different.
They will
And
not
then-
destroy the clot.
So when the clot forms, there are two factors. One is fibrin mesh, and the platelets come and aggregate, and the clot is formed. When we give antiplatelets, it will prevent platelets to come and form clot. But when the mesh is already there, platelets are already there, and clot is there, antiplatelets alone will not work.
And clot is
The
basically
only function it will have is to prevent any further increase. But the clot which is already formed, I have to give thrombolytic agents, where the drugs will dissolve everything.
so clot
and
is
reopen
basically
the
the blockage in artery.
Blockage
That is
in the
what
artery.
we mean when we say clot.
Clot is
And you have to
a blood
remove the clot.
A person can know what is a clot. When you have an injury, the blood starts coming up. Then it stops. And there is a blood which is coagulated, thickened. That is clot.
That is clot.
That is
And
clot.
that is there in your
And that
arteries.
is what you see here. Something similar happens in the artery.
In the arteries.
And the flow gets blocked. There are what happens in diabetes, dyslipidemia, that is high cholesterol and other triglycerides, and hypertension is your blood vessel starts accumulating the cholesterol in its walls. That is called as atherosclerotic plaque, and it starts building up. So the plaque has a cover and a core, which is cholesterol rich, fat rich, and by say raised blood pressure or something, that plaque ruptures. The continuity is broken. The moment it is broken, body senses it. It sends platelets to plug that break. It's like a dam opening. You put in something to close that. So the body sends platelets, and they keep on building. So it is not enough. Only required amount of platelets. They keep on coming, and they come to the extent that the clot becomes huge. So beyond the plaque, now there is a clot which obstructs the flow. And when you get a heart attack or a brain attack, the clot completely occludes the vessel. So there is no blood flow ahead. So now what the drug does is dissolve the clot. But that plaque which was there, it will remain. But at least the initial flow which was there will start. So the organ will start getting blood. So the earlier it will get the blood, lesser is the amount of neuronal damage. As sir was saying, each minute there is a neuronal damage in millions. So earlier you thrombolyze and open the vessel, less number of brain
Cells
cells
will die.
to be saved, or less number of cells to die, more to save. Second is, even if we are not able to do that, say the person comes to you beyond 4.5 hours, still there are good chances of recovery. Because when you use antiplatelet drugs, when you use anticoagulants, sometimes if it is a repeat stroke, what you do is prevent any further accumulation of the clot. Body's natural mechanism will take over and try to epithelialize the clot, put in vessels, new vascular in through the clot, and some amount of blood flow will be established. In a stroke, there will be a core area which is dead. There will be a penumbra of brain tissue which is surviving but not functioning. That part comes into functioning, and that's why there is a recovery from stroke. When I say that person, see, if somebody who has a stroke, he doesn't come to the hospital. He is not able to walk. By the end of 1 month, he will still be able to walk because some amount of brain function recovers. It is not that everything is gone. We have seen people who have brain semiparesis, like their limb was not moving. By the end of 2 months, with intensive physiotherapy, your brain learns to take over the function of dead cells. And you can still be able to walk with support. That's why now with newer drugs, early interventions, we are seeing recovery from brain stroke much better than what we used to see, say 10 years down the line. So reaching in hospital early, getting early interventions in the sense medical interventions or surgical interventions, either of them, your chances of coming out of stroke are good. If you are thrombolized in time, your chances of coming back to normal are excellent. You may reach almost 90% of your functional capacity. And that is very helpful in a person who is of earning age.
So, the other cells of the brain, the cells which are not dead yet, they take over the function of those cells which are dead.
That is a natural learning. Not only that, as sir was saying, if you train yourself in using left hand, right hand, your recovery of stroke is good. Not because your left side is functioning. It tends to take over your right side function also. Might be, as I said, penumbra cells are working, circulation is there, collateral. Some penumbra cells will get good amount of circulation from collaterals and they will start functioning early. So recovery from stroke is bound to happen.
And sir, the injections, the thrombolysis injections that you mentioned, so there are a lot of types of those injections.
For brain, there are only two. One is TPA, which was universally available, which was very costly, almost 60,000, 70,000 in India.
Per injection?
Per injection.
60,000, 70,000.
Now, in India, recombinant TPA, which was used always for many years for a heart, but was not indicated officially for a brain, is now officially allowed to be used for brain also at a calculated dose. So the cost has come 1/3.
Okay.
So almost 20,000-30,000.
20,000-30,000 per injection.
70,000 per injection, depending on your body weight.
Mm-hmm.
So that is there. For heart, there are 3-4 type of drugs. For brain, there are only 2 type of drugs, which are either drugs which...
And the costly one is better.
No. Now there are studies which say they are equally good.
Okay. So
They are equally good.
take
The costlier one. No.
But this is as far as the brain is concerned.
Brain is concerned.
For heart,
Heart, there are drugs like streptokinase, which cost hardly 1,800 or 200. And RTPA, recombinant tissue plasminogen activator, which costs in thousands, 40, 50. But the efficacy is much more.
okay, so the costly...
The drug is costlier, but it is more efficacious.
when it comes to heart,
For brain, this low-cost medicine is not used. It is not a labeled indication for brain stroke. So for brain stroke, it is only tissue plasminogen activator which is permitted. Now, recombinant is also permitted. So the cost has come down.
okay. So sir, can you share some of the crazy patient
Yes.
stories?
Now we will come to that. I'm practicing in Panvel for almost 30 years. There are so many stories of heart attacks, but there are so many stories, almost say, not as much as heart attack stories because that is a different ballgame. For brain also there are stories. I have my patients. Currently I have a patient who is admitted in my hospital. She had a mitral valve disease, so one of her heart valves was narrowed. Because of that, the left atrium, the upper part of the heart had dilated. Over a period of time, as the left atrium dilates, through which the current goes to the heart's lower chambers, the current becomes heavier and the rhythm changes. So over a period of time, as your left atrium dilates, you tend to be more prone to develop atrial fibrillation, which is one of the risk factors for stroke.
Which is irregular rhythms
Irregular
of the...
rhythm of the heart. Because of that, what happens is, because of that irregular rhythm, the left atrium doesn't contract sequentially. Normally what happens is, the current comes from right atrium, it goes to the left atrium, it contracts, the mitral valve opens, the blood goes into the left ventricle, and then it contracts. In atrial fibrillation, the left atrium is contracting at such a fast rate that there is no blood flow. The blood pools, collects there. And some currents go down and the ventricle contracts. So there are times when the ventricle is full, there are times when the ventricle is not full. But the left atrium is always full and not moving much. So there is a tendency of clot formation. And when there is a sudden change in the heart rate, that clot gets dislodged from the atrium, comes into the ventricle, goes through the aorta, and many of the times, majority of the time, it goes to the brain because of the pressure. And that takes the patient, and the patient lands up with a brain stroke. And here the clot is much larger than what the clot is there in the brain arteries. Normally when the patient gets stroke, there are smaller arteries in the brain, so the smaller area of the brain is affected. When the heart clot comes from the heart, the clot is big. So large areas of the brain is affected. Something similar happened to my patient. She came with dense right hemiparesis. Her right side had totally been paralyzed. She was not able to speak. She was almost drowsy and saliva droopy. But she came in half an hour. We sent her for a CT scan. We got a CT scan in remaining half an hour. She had no other complications. Like when we give a drug which dissolves the clot buster,
we have to
be sure that she has no tendencies at other sites where she can bleed, like per-rectal bleeding, ulcers, recent surgeries, or if she ever had a brain hemorrhage for lifetime, she cannot be given that. Once that is ruled out, we gave the drug RTPA to that patient. In 3.5 hours, her power started coming back. In 6 hours, the patient's upper limb, lower limb had started moving, power grade of 5 by 5, 100% recovery of power. By 8 hours, she started speaking normally. Next day morning, the patient was normal. Absolutely. This is a miracle. That patient, if was not thrombolized, probably would have taken much longer and might not have recovered to the extent that she recovered now. So this is one advantage. There was one more patient where the patient had a mitral valve which was replaced, and she was on anticoagulants. When the patient has a metallic valve or any valve which is replaced, we have to give a drug which will not form fibrin clots, because then the platelets will come and form the
because that valve is synthetic.
Valve is metallic, it damages the RBCs, and the moment it damages the RBCs,
a clot will be formed.
The body senses that there is damage, structural damage. To block that, they will send material to close that. So the clot formation tendency goes up. In that patient, they need to be on drugs regularly when we have to check that the drug is acting. In the sense, their prothrombin time is prolonged enough not to allow clot formation. If that doesn't happen, even if the patient is taking the drug, they will still develop it. In my patient, what happened was the clot formed and it sat on the wall. So it blocked the wall. So the blood was not flowing from the atrium to the ventricle. She came in a cardiogenic shock, in the sense she was sweating, the organs were not getting blood because her BP had dropped. Fortunately, we had a cardiologist who was working in hospital ICU that time. He could diagnose that there is a clot sitting on this artificial valve. So the only thing that we could do and save the patient was immediately thrombolize. So we thrombolize that patient. The patient who had collapsed, not responding, BP unrecordable, cold clammy, that we say cardiogenic shock, and probably they are going to die in next few minutes to hours, because the organs don't get blood and the organs will stop functioning. The moment the clot got busted, and it happens in minutes, you give a drug, it goes to the site and dissolves. The flow established. By half an hour, patient started moving limbs. By 1 hour, her BP came back to normal. By say 6 to 8 hours, she started passing urine, and she was back to normal. We did her echocardiography again. It showed that the metallic valve, which has 2 leaflets, one was opening, the second one was not. So probably there was some amount of tissue remaining. This is enough to suggest that you should go in time. Story in this patient is, she came to us again after 2 months. She was on drugs and all, but she landed with left lower limb paralysis, only single limb. We again did her echo and fluoroscopy, and it showed that now both the leaflets are moving. So there was a possibility we considered that might be there was a small clot which was there, which was obstructing that one leaflet which was not moving. By movement or whatever it is, or with drugs, That part must have been dislodged. The wall started opening. But she landed up with a small lower limb weakness, which recovered in 2-3 days on its own. And the patient was normal. There was one story where patient came bringing a mother with a heart attack. From my hospital entrance, he lifted his mother, who was thin, brought her to the table, and by the time we were examining him, he started sweating and collapsed.
The son.
The son was 45 years old.
Mm-hmm. He collapsed.
And developed right-sided stroke. So again, in this patient, we were treating mother who had an infarct. We sent him for a scan. We did his scan, normal, thrombolized him, he also recovered. So he was lucky that he was in the hospital when he developed a stroke. So that golden hour was there. So he had 100% recovery. But this is good part of the thrombolysis. The bad part is people who are especially old, people who have a large size stroke, people who come late. People who come late may not benefit much, but people who are given thrombolysis and they are high risk, they can have a bleeding complication. The infarct, which was ischemic infarct, in the sense clot blocking the vessel and dead tissue, that dead tissue bleeds now because the vessel leaks. And that size of the infarct can increase because of the pressure of the blood. So the patient's deficit will increase. He may become comatose. He may need to be on ventilator. So there is always 10%, 20% risk that once you give a thrombolytic drug, the patient can have a complication. And we cannot guarantee that a young patient is there and he will not develop. He may develop, but his chances are less as compared to the elderly. But if it is a right-sided stroke, we should err on the side of giving a drug rather than holding on because of fears. Because your fear will come out only 10 to 15% of the times. 80% of the times it will help and successfully thrombolize. So you should not hold on thrombolysis out of fear, psychological fear. If there is a documented fear that this is going to happen, don't give. But if there are no contraindications, you should go ahead and thrombolize the patient.
Also, sir, one more logical question, as in when we say we thrombolize the patient, it destroys the clot. Now, a lot of times what happens is that the patient has done his angiography just for like a routine checkup, or maybe there is some pain in chest. The doctor told him, get your angiography done. That patient did his angiography. He found out that the obstruction, the clot in his heart is 50%. The cardiologist told him that, okay, it is just 50%, nothing to be done. In that case, can we give... can we thrombolize?
No.
As in, will it then destroy the clot?
If there is a clot which is friable, less than 50%, TIMI, there is something called a flow in TIMI 1, 2, 3. TIMI 3 flow is good flow, nothing is required because that clot will get disintegrated over a period of time. So nothing is to be done. If that clot is causing significant obstruction, there is something called a thrombosuction, that clot can be sucked. But if there is atherosclerosis which is more than 50% but less than 75%, usually stent is not put. But now there is a concept of friable plaque. 90% occlusion may be stable plaque which has no rough surfaces, no ruptures. But your 45% occlusion plaque, if it ruptures, it becomes active and there may be a clot development which will block the vessel. So having 40% block is not something which you can disregard. You still have to take your diet. You have to control your cholesterol levels by statins so that the plaque stabilizes. So the concept of plaque stabilization is that only. When a person gets a heart attack, you give high dose of statins so that the plaque also stabilizes. So that plaque doesn't call platelets to develop there. So it will prevent platelets from coming there and forming a clot.
No, but is there a way in which that can be removed?
Plaque cannot be removed. It can be pressed with stent. But plaque can be stabilized.
And a stable plaque is
less damaging because it will not form a clot there to block.
But what if that patient exercises and now wants to live a healthy lifestyle with good exercise?
So that can happen.
That can happen.
It is too, like if the person is 80 years old, he has plaques. He may be having 80% plaques also, but we may still decide not to do any intervention, because if he is getting symptoms as, say, after walking half a kilometer, I can ask him to walk quarter of a kilometer only and stop. He can modify his lifestyle.
Okay.
With significant obstruction, still an elderly can be managed medically without intervention. For any reason, cost, complications, risks of intervention. For a young patient, we cannot restrict his life not to work, not to go walk, not to exert, because he may have to lift his child, he may have to do that. So there you have to actively intervene if it is indicated. There you should not promote your patients all these other therapies that are going on. Diet control, medicinal control, and all this.
So they're above 75%.
If the block is more than 75, usually it is advised that you should
get it removed.
stented.
Stented.
The vessel flow should be normalized.
Okay.
That is the usual advice.
Okay.
Medical insurance we have covered. Lifestyle modification, medicines. And frequency of checking. How frequently you should check. As I said, diabetics, pre-diabetic, family history of diabetes, and age beyond 40. So your preventive checkup should go on properly. And keep faith in your doctor. Your doctor is going to advise you whatever is good for you. He is not going to give you medicines if they are not indicated. His whole idea is that you should get good benefit of the drugs. Majority of the time, this is the truth. Charges are variable. It is like a hotel. Whichever hotel you select, you have to pay accordingly. But each hotel will try to give you good food. I think you should keep a faith in your doctor also, same way. Whichever doctor you go to, his whole concept is, if his patient gets well, he will get more patients. Mouth-to-mouth publicity is the best advertisement for a doctor. He treats one patient good, that patient is going to bring more patients to the doctor. So this is a convention, but what I mean to say is, जे म्हणलं तसं परत मागच्या वेळेस कोट केलं तसं की पुढच्याला ठेच लागून आपण शाणे झालो तर उत्तम आहे सगळ्यात. आपल्याला ठेच लागण्याच्या आत जर शाणे झालो तर डॅमेजेस प्रिव्हेंट होतात, ऑर्गन डॅमेज प्रिव्हेंट होतो, तुमचं क्वालिटी ऑफ लाईफ चांगलं राहतं, मेडिसिन्स कमी लागतात. सो एव्हरीथिंग.
And any which ways, testing more often or spending money, extra money in testing is...
It is proved that preventive expenditure is way less than what you require for treatment.
This is what something...
See, it is proof. You can estimate if you land up with a heart attack and you go in an ICU for 2 days, 3 days, undergo a bypass or undergo angioplasty. If you spend X, if you do your preventive checkups, it will less than 1/10 of an X. And you will not land up with ICU stay and angiography, angioplasty. Same thing with diabetes. Diabetes is more so. It's a long disease. You have peripheral vascular disease. You will end up with a diabetic foot. Comorbidity, expenditure, quality life gone down. Everything leads to a very bad quality life, financial strain, and your life longevity also goes down.
Because the thing is that patients, even if they have diabetes or hypertension, they think कि मुझे कुछ नहीं होगा. Until they have to bear those expenses, they are just in denial. कि मुझे कुछ नहीं होगा. I don't need to. I take these medicines sometimes I don't take these medicines. But the actual truth is, if you are very strict about your medicines, about your lifestyle, only then you will be able to avoid hospitalization. Otherwise, hospitalization is inevitable.
See, there is a continuation of life, continuum, and there is a continuum of life with comorbidities. So if you are expected to live 80 years, up to 60 you may not face anything. After 60 you will start facing illnesses associated with age. If you have comorbidities, the whole continuum comes earlier. Your kidneys get damaged, your heart gets damaged, your brain gets damaged, your quality of life comes down. What happens at 70 will happen at 50 for you. And if you want to take it to 60, you have to be very careful about your diet, exercise, drugs, regular checkup, preventive checkup. So that is the whole idea. So you are a diabetic, you are bound to have microvascular damage. Try to make it as late as possible.
Thank you so much, guys. Yeah. I hope you had a
wonderful time listening to this informative session in which we talked about prevention, in which we talked about saving money, and the money that you would inevitably otherwise spend if you get hospitalized. So I hope all this discussion helped, and I once again thank you, sir.
Thank you very much. Thank you
for coming.
I also enjoyed the discussion.
Yes,
Because
definitely.
this is a good forum to make people aware of taking their medicines regularly, and preventive medicine is the best medicine.
Preventive medicine is the best medicine. Thank you, sir.
Thank you.